Hello, viewers. You'll be surprised to see me today because you're missing your regular host, Rashmi, today. But let me introduce myself first of all. I am Dr. M.S. Kanwar, Senior Consultant in Lungs and Critical Care and Sleep Medicine in the department in Apollo Hospital, Indraprastha Apollo Hospital, New Delhi. And I also am lead in lung transplant and look after the COVID team also as a senior member. Today we will be talking about not COVID, but something which is very, very important uh, in non-COVID times, of course, and that is obstructive sleep apnea. Sleep apnea, which in USA particularly is very well known because the maximum number of cases are seen there, maximum diagnosis is made there, and maximum therapies are given there. And in fact, way back, it was in USA, followed by, in fact, Australia, followed by USA, that made this disease so very popular, and awareness became so commonplace among public worldwide. So we will not be talking too much about the diagnosis. You probably know that obstructive sleep apnea is to do with snoring and sleeplessness nights, and also diseases which lead to from sleep apnea to so many other conditions. So we'll talk about that. So we'll be talking mostly about the treatment aspects, the medical treatment. I'll be discussing about that. And today we have one of the best robotic surgeons in Asia, uh, at least in South Asia, that we have in our hospital. He is Dr. Kalpana Nagpal, and he is a consultant, senior consultant in ENT, head and neck, and robotic surgery, and has done the maximum cases in sleep apnea surgeries in India, and also doing a lot of robotic thyroidectomies, scarless thyroidectomies in India. So, welcome to you, Dr. Kalpana Nagpal, on the show, the Health Talk Show.
Thank you, Dr. Kanwar.
So we talk about a lot of things, a lot of aspects about the hospital and diseases and our cases across the table in the hospital. Almost every day, there is some point of discussion, but today we'll be in Rashmi Bedi's show, and we'll be talking to the audience in general, global audience, and I would like to know your views on how you manage those cases of sleep apnea who are referred to you for surgery. But we'll come to that later. In fact, let me tell the audience before that as to what are the medical therapies, so that usually, we move like that, and we are very selective where a surgery could help. We jump in with the surgery sometimes in the very beginning, and where we feel that other therapies, even simple means like weight reduction and postural adjustment, side on sleep posture can help. There we stick to those simple means, but there are some cases where dental appliances are required. There are some cases, very few, where mandibular enhancement technique surgeries are required. I would want Dr. Kalman Nagpal to talk about that. Before that, I would just tell you, when a patient, when often an obese patient, somebody who comes with a history of snoring, excessive sleepiness in the daytime, and poor poor sleep at night, and who tends to doze off, sleep off at any time in the day, and sometimes may even have depressive symptoms, anxiety symptoms, comes to you. What do we do? We do a sleep study for the patient, of course, after going through all the clinical data, history, and throat examination. We often send these patients to the ENT specialist, Dr. Kalpana Nagpal in particular, to look at the throat and see how good or bad it is. There is a Malampati score we look at to see how narrow is the upper airway. So passage. So we score them like 1, 2, 3, 4. So depending on the degree of narrowing, sometimes we do sleep endoscopy to see during sleep. If we induce sleep in the patient, then how much narrowing worsens and how the apnea start to develop right in front of us when we are seeing the patient through the endoscope. So uh, once the sleep, it is decided that the sleep study is required. It is a complete overnight polysomnography test whereby more than 20 channels are applied and the patient is supervised by the technician. And there is a huge data of about 1,000 pages that I go through. And it takes about an hour and a half to go through one complete study. And then we decide, depending on how much is the severity, as to whether it could be something which could be corrected by surgery, or it is something which is a straightforward case for a therapy called CPAP, which is the most commonly used therapy in the world, continuous positive airway pressure, CPAP. And there are various types of machines, but uh, you first of all have to decide whether the patient is young, patient is in the older age group, patient is very obese, is he having a condition called hypothyroidism, whereby there are some reversible elements which you can correct in the patient, and then you have a long-term view of the patient, whether this patient would require a CPAP therapy for long term, or we can do away with those things and correct surgically, especially with the robotic surgical procedure in the very beginning, and get him out of the mess by reducing the apnea index. Now, what is the apnea index? I may briefly tell you. The number of chokings or apneas per hour is taken as the apnea index. If it is up to 15 per hour, then it is considered mild. If the apnea index is 15 to 30, then we call it a moderate disease. And if it is more than 30, then we call it severe disease. And if it is very high, and especially if the oxygen is fluctuating a lot during sleep, it is falling, oxygen is falling, we call it very severe. Sometimes the oxygen is in dangerous levels. We call it life-threatening obstructive sleep apnea. So, uh, we decide at the time of reporting whether this could be a case where a permanent cure with surgery can be obtained, and the apnea index, suppose the apnea index is 60 or 70, and we feel that the patient would be not completely corrected by surgery. We may reduce the index from 60, 70 to 20 or 30. The disease still remains, then we are hesitant. We discuss with the patient family. But if the index is something like 25, 30, Dr. Kalpana would say even higher, because she has those data with her, and she's even probably quick at picking cases with an apnea index of even 50. But uh, in general, global researchers and reports and papers have certainly shown that if a good job is done, now it's very important, if a good job is done by surgery, and that number of apneas per hour are 25 or 30, even 35, and a good job is done, you could probably reduce it down to even 5 or 10 or even less. So that means you get the patient out of the mess forever. So that is what we actually try to do through a surgical procedure. If we don't want to subject the patient to CPAP for life, well, in different societies, different kind of severity is seen among patients. In USA, I know lots of patients they fall into severe category or very severe category. In India also, it's about the same. But then there are lots of cases who have milder disease, relatively milder disease, and who also have a condition called upper airway resistance syndrome, in which is something like akin to apnea, but the oxygen doesn't drop. The arousal mechanism in those patients is so sharp, means even with a little tug here, a little obstruction here, the patient gets aroused. So if the patient is aroused, this choking disappears. Once this choking disappears, the flow is restored, so the oxygen will be maintained. So in those patients who have a very low arousal threshold, they do not tend to develop apnea easily, but they have upper airway resistance syndrome here, and they have a very high arousal index, and they wake up quickly. So we have to select these cases. What are the best cases for surgery? Now, I will come to Dr. Kalpana Nagpal to first of all throw her experience and light on to the surgical procedures in obstructive sleep apnea. Yes, Dr. Kalpana.
Yeah, I would like to tell the audience that I've been treating sleep apnea patients for a very long time, at least 15 to 20 years. And in fact, I had exposure to this in Atlanta School of Sleep Medicine. And after having performed sleep apnea surgeries for a very long time, even the sleep surgeons all over the world agree that the results were not so very good. Now, for the last 5 years, things have changed dramatically since the advent of robotics. Now, robotics, with the advantage of superior visualization of the anatomy and also able to reach inaccessible areas, meaning lower down the throat, if there are levels of obstruction and these sites of obstruction actually causing narrowing of the airway, the robotic instrument arms are able to reach those areas. And now these kind of surgeries with the robot have changed the whole scenario. So we're getting great feedback. Now, what do we want actually? The patients come and ask for disappearance of subjective symptoms. Most of these patients are suffering from daytime sleepiness. I've been getting a couple of IT people, CEOs, officials from even abroad. Like there was a couple of doctors I operated recently. People are traveling from far and wide only to come and say, Doc, please, I do not want to be having daytime sleepiness, and please improve the quality of my life. Of course, we do polysomnography for all the patients, and as Dr. Kanwar said, selection criteria is very important. BMI is very important. If the BMI is less than 40, and if the patient falls in the mild category or moderate category or early severe category, they have excellent results. In fact, we have maintained a register, we have collected the feedback, we have testimonials, live testimonials, and this is for you to actually believe when you read and hear those people. I mean, they've written with their own handwriting about what exactly they've, what parameters have improved. Following robotic surgery, after 3 months or after 4 months after surgery, we get the polysomnography repeated again to see how many statistics and what kind of parameters have improved. Now, surprisingly, patients have told me that those who were on antihypertensives for a long time now are having to stop the medications. They don't need it anymore because the BP is, under control. And patients who are diabetics, they're off insulin. I mean, I've had at least 10 to 15 patients in the last 6 months who are completely off insulin. And apart from that, the weight loss, normally sleep apneics are unable to reduce weight despite advising them weight reduction, because weight reduction is part of the management. Both the medical physician as well as the surgeon always emphasize that the weight loss has to be part of your treatment program. And somehow before the treatment, it's very difficult for them to lose because, obviously they can't run, they can't, and the fatigue sets in early. Now, after sleep apnea surgeries, we have had patients who are able to lose even 20 kilos weight, and that makes them very happy. So they become more alert, the memory comes back fast. And now what is exactly the robotic surgery doing? Now, base of the tongue, that is backside of the tongue, is the main culprit in most sleep apnea patients. As all physicians and surgeons all over the world have done various research and have had various DICE studies where, Dr. Kanwar just mentioned, you have a simulation study, you give, drug like propofol or something, make them sleep, so you're inducing sleep, and you are looking at the airway, levels of obstruction. I mean, what is the exact narrowing? Like, is it happening at the level of palate or at the level of tongue or at the level of larynx? You come to know. And now various studies have been collected from various countries, and it has been found that base of tongue is the main culprit. And that is why, now earlier surgeries on base of tongue before the advent of robotics was very cumbersome. And it led to a lot of morbidity because you need to have big scars outside, external scars, there's a lot of bleeding, and also you're not able to remove sufficient tissues, it's all in piecemeal. Whereas in robotics, like, I would love to even share videos with the audience if anybody is interested. It comes as a single piece, and we remove significant, especially, except for the first initial 10 cases of my series. After that, all my cases, we've had significant removal of base of tongue. We remove more than 15 cc's. Most of the times it is 25 to 30 cc's, 30 ml, volume of the tongue. Well, we cannot remove too much or too little, because too little will not give us good results, and too much removal will cause aspiration issues. So it's very important to learn the technique. I've improvised the technique over the time, and now our techniques are giving us good resection, single piece, and we avoid the lingual arteries, which is, these are potential big arteries in the tongue which can cause, excessive bleeding. So once you learn the technique, it is just a fantastic thing, and I would really thank the inventors, whoever have invented the robotics. And so that's how.
Which machine are you using, Dr. Kalpana, in your hospital, in Apollo Hospital?
Actually, it started off with Da Vinci robot, because Da Vinci USA, Sunnyvale, they have the manufacturing unit. I had a chance to go to Sunnyvale, and it's a very large manufacturing unit. Every week they are, manufacturing robots, and we have engineers from all over the world, even from India, Korea, etc. And the model that we have been using is SI system, but we are soon getting, and next month we will be getting XI system, which is even more advanced. And well, in the USA, they already have a single port robot, which means there's only one channel in which both the endoscope as well as the instruments are introduced. The advantage of this transoral robotic surgery, which means the robotic surgery that's happening for sleep apnea and head and neck, there are no cuts from outside, even to introduce the ports. They hang in the air because you can open the mouth wide using special retractors, and so all these instruments are directly introduced into the mouth. So there are no external scars, and there's good visibility, there's 3D vision, and 10 times the magnification. The dissection is so precise. And even the viewers, in the operation theater, everybody gets to watch the surgery.
So great. So we understand the advantages of robotic surgery, especially in those areas where there is a narrow field of view. So certainly that is where the robots have been gradually perfected, and the innovations are going on and on. And so you have every couple of years, I'm sure you're having a newer model with some modification, with some further improvements. I'm sure you're looking at that. How did you develop interest into into robotics in particular?
Well, when I was performing these regular ENT surgeries, I would look at the robotic machine from a distance, and those days only the urologists were performing robotic surgeries, this was perhaps in 2014 and 15, when they were doing robotic surgeries for prostate CA. So I was finding it very interesting. And then when I watched their videos, etc., and one or two live surgeries, I thought, why not an ENT and head and neck? And as it is, I have this little engineering background in the sense I always loved physics, and perhaps that led me to this special interest in robotics, and then decided to go to Korea and South Korea, see all where I got trained. So basic and advanced training in robotics. That's how
So
I
you had to
started.
go all the way to Korea to learn the procedure and the basics. But is there any, have you been able to develop any centers or training centers or facilities in India now where you could train the budding doctors or anybody who is interested, who is a ENT specialist, but who wants to go into robotics also and wants to jump into and have a proper training program? Do you have a module of something like that?
Well, I have sent proposals to everyone, to the Prime Minister's office, to the Vice President, to our chairman, and I've sent proposals to various. I think it's the corona that has stopped everything, and we should be otherwise having a head and neck center exclusively within India. I'm already a mentor, California. I mean, the Da Vinci. Intuitive surgicals, they have given me mentorship, and so mentorship rights, and there are people who are coming to observe me. We had recently one of the cancer surgeons coming from Tata Memorial Hospital. There was a surgeon from Bangalore, ENT surgeon, who came and observed. There was one from UK. There were a couple of surgeons from Ghana and Kenya. So we've been getting a lot of observers from different countries. There was one lady from Iraq. So now, unfortunately, we still do not have exclusive robotic center for head and neck training. Now, I need a large cadaveric lab. Now, getting cadavers in India is not easy. Surgeries have to be first performed on cadavers for people to, perform on live patients. So there are a lot of challenges to actually start this program, but I'm very, very keen, and I hope it's soon before 2022.
Yeah, I hope once the corona peaks are over and the life comes back to normal, your queries to the PM's office or the vice president's office, they would be answered. Until then, I don't see any hope that anybody would be thinking anything outside the corona box. Um,
Yes.
do you do you think that robotics adds a significant amount to the cost of the procedure, or is it something which is not exclusively different than what should be an otherwise normal UPPP, uvulopalatopharyngoplasty procedure?
Well, in the US, it is very expensive. Most of the surgeries are 10 to 20 times more than the costs in India. So that's why people are traveling from abroad. As mentioned recently, I mean, I also said patients are coming from abroad only for cost issues, perhaps, and of course, availing skilled procedures. In our country, it's not really expensive. It is 60 to 70,000 rupees more than the traditional surgery. So it's added instrument cost only. There is no added surgeon cost because since we are still in the process of creating more and more awareness and having more and more volumes, and also probably there are more newer robots coming up. Like there are several companies now giving competition to Da Vinci people. There are, robots manufactured by Medtronics and by Johnson and Johnson, and some of them are coming from Korea. Already Hyderabad and Chennai have some robots which have come from, some of these countries and which are not Da Vinci, and they're cheaper. And so slowly we're getting, and there in them the instrument cost is even lesser than 60 to 70,000 rupees. So this is the only additional cost, whether it is a robotic thyroid surgery or a neck surgery or a throat cancer surgery or sleep apnea surgery. The added cost as compared to traditional surgery is roughly only 70,000, 80,000 rupees. In dollars, I can tell you the total cost of these surgeries is averaging between $2,500 to $5,500,
All right.
depending upon the
Uh,
surgery and the type of this choose, etc.
okay. Enough about the robots. I'm glad you explained everything in details. about not only the procedure, but the robotic instruments also, and how the advancements are taking place and the newer competition is coming through, which obviously would lead to better equipments in future. Not that they have any major flaws, but there is always a scope for improvement in all kinds of instruments in future. Let's just talk about a little about. Let me tell you, uh, I have been looking at sleep apnea patients since the year 1993, when we set up the first lab in the Middle East. That was the first lab, and we were all learning at that time. So we were learning to see the patients of sleep apnea and to do their polysomnography, and we were learning the EEGs, the EOGs, the all the waveforms that are generated with lots of electrodes that are placed over the body, something like 20 to 25 electrodes. And so once we mastered that, it took many years. It's been now something like what, 28 years since I've been looking at sleep apnea patients, and 25 years, 26 years now in Indraprastha Apollo Hospital, Delhi. So we have a wealth of experience. We've published our work, and um, we had our training sessions, we had our sleep fellowship courses, so trained people on that. And I have been an examiner in sleep fellowship program conducted by the Indian Sleep Disorder Association. So we have wealth of data experience on that. And what our experience shows is that those patients who are very compliant with the treatment, they do very well in life as far as sleep apnea treatment is concerned, and future life is concerned. Otherwise, they have a tendency to develop, as Dr. Kalpana said earlier, to develop diabetes, hypertension, dyslipidemias, means high cholesterol, increased risk of heart attack, increased risk of brain stroke, psychiatric illnesses, anxiety, depression, and the quality of life goes down. Social life gets affected, and people lose their jobs. And people who are into those kind of jobs where mechanical machinery is used, or people who are in driving industry, train, flying, or bus driver, cab drivers, in these professions, it's all the more reason that they should be completely rid of sleep apnea. Otherwise, they will lead to not only a increased risk to their health, life, but to the life of others also. So we have found that patients who are compliant with the treatment, and whether it is a CPAP or whether it is lifestyle changes, reduction of alcohol intake, or weight reduction, and maintaining a proper diet control. Uh, and if somebody is using a CPAP device, using the CPAP regularly, daily, for 7 to 8 hours, if they are doing that, then they are doing wonderfully well. If they have done a surgery, subsequently also they should keep an eye whether some symptoms appear, because do not forget that as the age advances, the sleep apnea tends to increase, because the muscle tone of our pharyngeal muscles and tongue muscles tends to go down as we grow older. And of course, it goes down when we are sleeping. That is why the collapse happens here, and the choking and the obstruction takes place. But as we grow older, and in females in postmenopausal stage, also there is increased tendency to develop obstructions. So, this is not that you do the treatment once and then you are done for life. You're fine. You should get a periodic check from time to time. Both, if a surgeon has operated on you, you should see the surgeon from time to time, or whosoever is a sleep specialist who has diagnosed you, or who's looking at you, who's following you up. You should see the doctor from time to time, so that Any new changes happening are picked up early and are not ignored, and also ensured that your device is being used properly, you're tying it up properly. There are applications which tell us whether, when I go through the data of, let's say, last 6 months, I would know whether the patient is, how much the patient is using, whether the patient is interrupting the use, whether the patient is missing the days of use of CPAP, or whether there is uh, any any loose mask, or the mask may be defective. There is a leak of air which is unacceptable. If these things are happening, then and sometimes another thing happens. Sometimes the patients, after using CPAP, the disease comes down and he loses weight, and he controls his diet, and the disease comes down significantly. Then we decide, well, now is the time for the patient to go for surgery and get rid of the excess tissue which is causing the blockage. So we can decide about doing a surgery in the beginning, or in a relatively milder case, not a very severe case, or we could even do it later once the patient has been compliant and has also reduced his severity of this disease. Then again, we can pick the case for robotic surgery in particular, where the results could be gratifying. Uh, Dr. Kalpana, it has been a pleasure talking to you. What would be your take home message for the audience?
Yes. Most people ignore snoring and sleep apnea. Now, since I'm an otolaryngologist and I have been looking into throats every day, at least on an average, I pick up 10 patients a day. And most of them, when they come for their preventive health checkups, because more and more people are conscious about their health, so they're getting their preventive health packages. So during that screening, some of them are identified to have sleep apnea. They don't have to come up with the history. Just seeing the throat, I'm already seeing some swelling in the palate, and there is some typical signs which, tell us that it is sleep apnea. So we tell the patient to go for sleep study, but unfortunately, it is only 30% of patients who take this seriously. So the take-home message would be, please do not ignore your snoring, because snoring could be associated with sleep apnea, and sleep apnea could lead to a lot of comorbidities, so beware.
Thank you so much, Dr. Kalpana, for
Thank
being
you.
on the show and explaining to our viewers. I hope, viewers, that you did not miss Rashmi too much today. Number one. Number two, you could take home some messages, and especially those people who are obese or who are having sleep apnea, who have already been diagnosed as sleep apnea, need to be careful about their problem in future. Thank you so much, and good night.